Hello, everyone, and welcome back to the Journal of Oncology Practice podcast. This is Dr. Bob Miller, consultant editor for the journal. The unsustainable trajectory of healthcare costs in the U.S. has occupied much of our national attention in recent years. Healthcare comprises 17 to 18% of gross domestic product, and the per capita costs are the highest by far of any developed nation. And while cancer is in total responsible for only 5% of current healthcare expenditures, cancer care costs are expected to grow 40% from 2010 to 2020 to a projected $175 billion a year. To date, no consistent solution to reining in cancer care costs has been identified. However, one potential option that seems to offer promise is paying for care by the episode. In this podcast, we're going to be talking to Dr. Lee Newcomer of United Healthcare about a pilot study published online in the JOP on July 8, 2014, entitled Changing Physician Incentives for Affordable Quality Cancer Care, Results of an Episode Payment Model. Dr. Newcomer is the Senior Vice President for Oncology at United Healthcare. He practiced medical oncology for 10 years, and after earning a master's degree in health administration, he became the Chief Medical Officer at United Healthcare. He left in 2001 to start his own company and was chairman of the board of Park Nicollet Healthcare, a 1,000-physician multi-specialty clinic. He returned to United Healthcare in 2006 to focus on cancer issues. And welcome, Lee.
Thank you, Bob. It's good to be here this morning.
So before we talk about the specifics of your paper, I wanted to ask your opinion as to why you think it has been so difficult to revamp the current reimbursement structure for medical oncology care. I mean, most participants openly acknowledge that it's irrational and there's a lot of inequities. Do you think that's because we just haven't come up with an alternative methodology yet, or are there entrenched pockets of resistance wishing to maintain the status quo?
Well, I think everybody fears change, and our natural tendency as human beings is to hang on to what we have, even if it isn't working as well as we'd like.
Sure.
And the fact of the matter is that everyone's systems are built to bill for fee-for-service and pay for fee-for-service. So any change that we would put in place would require a lot of massive changes in our billing systems and our claims payment systems. So it's not surprising people are resisting changing from fee-for-service because it's what we've been using for 50 years.
Sure. Now, I want to ask you about United Healthcare's effort. Specifically, in your paper, you talk about a cancer registry with 65,000 patients with various cancers. Can you tell us a little bit about what type of data that contains, and how did that enable you to carry out this pilot?
Well, that registry was absolutely critical to us being able to do the kind of payment we talked about. It started actually as a little garage project about 4 years ago when two of the employees on my team began sending out fax forms to oncologists' office. It's a single page, and it asked for some essential elements that you would give to a tumor registry. What was the patient's stage? What was their histology? Are they being treated for curative intent? In other words, adjuvant treatments, or were they being treated for palliation with metastatic disease? And then we also asked for some very basic genetic information like HER2 status in breast cancer or the KRAS gene in colon cancer. It's a one-page form, and to our delight, 60% of oncologists return those forms. Normally, when we send a fax out, we get about a 1 to 5% response rate. But I think people were interested in finding out what we could do with that data. That grew dramatically. It's now an automated process. And as we put in place our online prior authorization tool this year, it will collect that data automatically from the physician at the time they do their prior auth.
I see. So the physicians won't have to enter it manually anymore, you're saying?
That's correct. And we have 65,000 patients on a voluntary basis, but this should grow now by 20 to 30,000 patients per year.
Oh, that's very interesting. So let's talk a little bit about your paper. You collaborated with 5 volunteer medical oncology groups for the pilot. And you say there were 4 elements of the previous fee-for-service contract that you changed. Can you describe that?
Sure. There are the four things that we asked physicians to do were the following. First, they registered the patient proactively by giving us that clinical data. And that allowed us to then set a linkage in our claim system between that patient's clinical data and the claims that we saw coming through. The second thing we did was change how we paid them. So we gave them a very large payment the very first day they saw the patient, and that large payment represented all the money that they would have made in drug profits from the planned chemotherapy. Instead of giving that out each month in smaller portions, we gave it out all at once on the first day. The third thing that we did, because we gave the drug profits up front, we paid subsequent chemotherapy at just average sales price. So in our contracts, we had agreed to pay a profit margin on the drug, as every insurer does. But because we paid it up front, now as they treated patients, we paid them only the cost of the drug. And that became important because if the drugs had to change, if there were new drugs that were being introduced, the physician was always paid the cost of the drug. They were never placed at risk for the drug cost. And then the fourth thing, which turned out to be critically important, was that we met every year to go over all the data that we were putting together on the profiles of the patients these 5 groups were treating. And that was an open meeting with identified information so that we could learn from each other. The people that were doing things that were good could teach the rest of us what we could do to improve. And when we spotted large variation in practices, it gave us a chance to discuss why those variations occurred and what we might do to reduce the variation that we saw in the data.
And you're saying these meetings were with all of the groups together in one room with United Healthcare?
Yes. The lead physician, the lead business manager from each group attended, and my staff from my team was also present. And as we looked at the data, it was identified. So each group knew how they compared to the other groups in this team.
Now, you talk about a clinical episode, and you talk about an episode payment. So I think you've already addressed the episode payment. But tell us a little bit about what were the types of clinical episodes, and what did that really mean? How did that affect the reimbursement structure for the physicians?
Well, we limited our clinical episodes to breast, colon, and lung cancer because that represents about 65% of the cancers in any oncology office. We had to start somewhere a little bit simply. And then in order to create an episode, we asked the question, well, where is there broad agreement on the general strategy, but maybe a lot of disagreement on the specific tactic? So what do I mean by that? I think if we had a room with 100 oncologists in them, and we asked, should you give adjuvant therapy to a stage 3 colon cancer patient, we'd have 99% agreement that, yes, you should do that. If we ask which regimen, we might get lots of debate about one versus the other because there are several available options for that treatment. And that's what we wanted in an episode. Uniform agreement on the big strategy, but lots of variation underneath. And the intent was to then begin to study that area and let people commit to the regimen they thought was best. And as the data developed, maybe we could learn which regimens, in fact, did work the best.
Now, were the practices required to use NCCN-approved regimens or other evidence-based guidelines?
They were. When they declared their regimen for the adjuvant care, we did use NCCN as the baseline requirement, and there are multiple options there. For metastatic disease, of course, patients would have been treated with multiple different forms of adjuvant therapy. So we didn't make these groups commit to a specific regimen for metastatic disease. We let them use whatever they believed was appropriate for that particular patient. We did ask, however, that those metastatic treatments be compliant with NCCN recommendations.
What about hospital costs or other case management costs? Was that covered within this reimbursement structure as well?
Yeah, the episode payment included the drug profit margins from the regimens they were going to use. And then we also looked at each of these episodes in our database of 65,000 patients and said, how often were these patients hospitalized, and what were the charges from the medical oncologist taking care of them in the hospital. That average amount of money also went into the episode fee. And then finally, we added a case management fee that was just an arbitrary number, a small amount of money to help defray some of the administrative costs of doing this program. That meant when a patient was hospitalized, the physician had already been paid for taking care of them, so we did not pay any fee-for-service E&M codes for the oncologist if the patient was hospitalized. Now, that didn't involve very much money, but it sent a strong signal that we wanted to pay attention to managing symptoms in the office and avoiding hospitalizations if at all possible. And to counterbalance that, we continued to pay all office visits fee-for-service so that the physician was never at risk for his office time either, but he was at risk for hospital E&M time.
I see.
That turned out to be important later because, as we'll discuss, hospitalization rates went down dramatically.
And how about radiology and lab? Was that paid on a fee-for-service basis as well?
They were. Everything else was paid fee-for-service. Drugs were reimbursed at the average sales price only, and the episode fee was never changed until the end of the study. The only way that you could raise the episode fee was either to improve the survival of the patients or lower the total cost of care.
So what were the primary and secondary metrics that you were looking at and were interested in measuring for this pilot?
There were two primary metrics. The first was, what is the total cost of care for taking care of these patients? And the second was, what was the total cost of chemotherapy medications for each of those episodes? There were no secondary metrics. We did do some subset analyses in the paper, but the only two primary metrics we were looking at was total cost.
Okay. And did the total cost include retail pharmacy claims, or was that excluded?
Retail pharmacy claims were excluded. We don't have complete data in our comparison database for that, so we had to leave those out.
So let's discuss the results. You note in your paper that there was a net savings in total medical care cost of $33.4 million using the episode payment model when compared to what you had predicted for fee-for-service. So can you elaborate on that a little bit and tell everybody what the surprise was regarding chemotherapy drug costs?
The registry became absolutely critical to doing this calculation. Because what we did was looked at the 810 patients treated by the episode payment groups, and we took that mix of patients and said, if they were in the registry being treated under fee-for-service, how much would we have paid to care for those patients? And the answer was around $99 million. So our group came in at almost a 34% reduction compared to what it would have cost to treat those patients in fee-for-service medicine. And it's the registry that allows us to do a cohort comparison trial that is adjusted for the type of cancer and the type of stage that patient has. That's a critical component because just looking at pre- and post-periods, there can be so much change in the mix of patients that it gives you an inaccurate answer. Now, we did see a rather dramatic increase in the drug costs. Our expected drug costs would have been about $7.5 million, but the actual cost for our pilot group was $20.9 million for drug costs. By taking away the incentives to use drugs, you didn't make any more or any less money. We expected that drug costs would probably go down. In fact, they did not. And it really doesn't matter because the important thing is the total cost of care went down very dramatically.
So you're saying that drug costs were almost 3 times higher, but the total cost of care went down. That's amazing.
Well, I think it does reflect how much of cancer care is involved, the cost of cancer care involves other services. Drugs only represent about 25% of our budget for cancer care at United Healthcare. And the remaining 75% is hospital, technology, other physicians, and so on. And there's lots of opportunity there to reduce costs.
Now, were you able to peer into the data any more deeply, say, looking at subsets, maybe any endpoints like survival? Did you look at that at all?
We did. Survival is measured in all of these groups. Now, with 810 patients in 3 years, some of the survival curves aren't mature enough yet for us to run statistics. But in lung cancer, we did have enough patients and enough time, and the survival curves showed no statistical difference between fee-for-service medicine and the episode pilot groups. So the outcome, at least from a survival standpoint, was the same. Two things that we were able to measure with enough statistical validity: hospitalization rates went down dramatically, and the use of radiation oncology went down dramatically in our pilot groups.
Was radiation oncology included or accounted for in the episode payment, or was that separate fee-for-service?
It was all separate fee-for-service. Now, radiation oncology, of course, was calculated as part of the total cost of care.
I see.
We looked at every service that patient received, but the physician was not at risk for that. The physicians actually had no risk or downside risk whatsoever in this program, because they were being paid the cost of the drug constantly, and they were not responsible for other services from a financial viewpoint. We measured it.
But you're saying, but nonetheless, radiation utilization went down.
It did.
Interesting. Huh. Any theories as to what caused that?
We have lots of theories, Bob, but no answers. Now, the reason for that is that it took 810 patients to reach the statistical power just to ask the first two questions. Did we reduce total cost of care? Did we reduce drug costs? It would have taken thousands of more patients to start to parse out these next levels of questions that everyone has, including us. So as we get more experience here and as the program broadens, we'll start to be able to get into those kinds of details and see if we can provide some answers.
So you note that there really were two interventions studied here, the financial incentives and the data sharing among the participating practices. I think you said the data sharing was done across the 5 participating groups. Can you elaborate on the process a little bit?
The data sharing was probably the most important thing we did. We set the table with the financial incentives, but the data sharing is where we all learned. These practices, for the first time ever, were getting information back about how well they cared for their patients. That data just isn't available. But by combining claims data with the clinical information they gave us, we could compare how their patients were faring against the other 4 groups. And we did deliberately identify all of the groups as we looked through the data so that they could learn from each other. I talk in the paper about one group that had very, very high hospitalization rates. They were a clear outlier compared to the rest of their peers. And in the discussion, we couldn't find an obvious reason for that, but as you would guess, once the group got home, they started pulling charts and trying to figure out what had happened. It turns out that their physicians appropriately said to a hospitalized patient, "Come and see me in the clinic as soon as you can." The patient would go home, make an appointment, and it would be 30 days because the clinics were full. And so they would end up coming back to the hospital. And by changing their process that guaranteed a hospitalized patient a return visit within 2 days, their hospital rates dropped dramatically. One of the other groups put a full-time nurse practitioner in the hospital to care for their patients, and they were able to shorten their length of stay dramatically. So there were different solutions for that problem, but by looking at the data and comparing each other, we found out that it was possible to get better. And we had countless examples of those kinds of discussions that became critical in learning how to improve. One of the most important things about that discussion is we never said, your data is bad, that you aren't performing well. Instead, it was, wow, there is a difference here. What could account for it, and how could we make that difference smaller? In other words, no blame.
So, Lee, talk about the future a little bit. Do you have any plans for additional studies of this nature, looking at a larger number of groups or broader tumor types?
We do. The original 5 groups are now going to be extended another 3 years. So we hope to double the size of that patient population. And we are offering this program to other groups. We hope to have at least twice as many patients on the program by the end of this year, and maybe 3 times as many by midsummer of next year. So we do want to confirm that we get similar results with other groups. Like any good experiment, you do need to duplicate your results and be able to reproduce them. And this is a one-time event. It did show dramatic savings. The statistical and study designs were quite solid, but we want to make sure that we can duplicate the results as we would with any good experiment.
Do you anticipate any barriers that maybe you didn't see with the pilot if you broadened it a little bit?
Well, the biggest barrier in this program is size. It takes a practice a fair amount of time to accumulate this many patients. So the thing that discourages both the medical groups and us is that it often can take 2 to 3 years for us to get the results. So one of the things we're working on is how could we put larger groups together to work in a collaboration. Maybe we need a pod of 10 medical groups working together instead of 5. And we do not have a solution for that 4-man medical oncology practice, as they just can't accumulate enough patients to ever have a statistically meaningful result. So this has worked well for the larger groups, but we're now starting to think about what could we do for smaller medical oncology groups to try and get some good evidence about their performance.
And finally, you appropriately urge caution in generalizing these results. But what kind of conclusions do you think can be drawn from a pilot such as this that might inform next steps on a more national level, say, for government programs and for cancer care reimbursement that all oncologists face?
Well, I think the very, very encouraging thing about this program is that we were able to show that you can substantially reduce the cost of cancer care without affecting outcomes. The lung cancer patients demonstrated that you can still get exactly the same survivals and take out substantial amounts of cost. You can reduce hospitalizations dramatically, in fact, improve the quality of care. Hospitalizations are a failure of care for an oncology patient. They represent a symptom that's out of control. And the fewer of those we have, the better the care, and more importantly, the lower the cost. So the very good news here is there is an opportunity to reduce costs for cancer care and make it affordable for our country. You started with some very good statistics about the overwhelming costs that are facing us as a country. If we can reduce those, that means we'll have enough payment to get people treated for cancers that can be cured. That's critical. And that's encouraging to me.
Dr. Newcomer, thank you so much for joining me on this podcast and sharing the results of this provocative study with us.
Thanks, Bob. It's been a privilege to do so.
And thanks again to my guest, Dr. Lee Newcomer, for discussing this important paper with our audience. The full-text version of the paper is available online at jop.ascopubs.org under Early Release Articles. Scroll down to the July 8th release date. We appreciate your listening to our podcasts and your interest in the JOP as always. This is Dr. Bob Miller for the Journal of Oncology Practice. Thanks for your attention.